Good morning, everyone. It's nice to see you, and I am so delighted to be here and introducing Arun Sridhar, and so happy to see you come back and visit. Arun was born in Chiang Mai, India, and did his medical degree training at the Gandhi Medical Center. And then he immigrated here to the United States to go to the University of Alabama for a master's in epidemiology. I followed that with training in internal medicine at Georgetown, and then went to University of Kansas for his cardiovascular disease fellowship. And I think that's where he really fell in love with EP, working for a really wonderful group doing great research. He went to the Cleveland Clinic for EP fellowship. And I remember in 2017, when we were working so hard to recruit him here, talking to my friends at Cleveland Clinic, and Arun, he just seemed so humble and just so kind, and in initial presentation really just laid back. And at the Cleveland Clinic, they were like, this guy is so brilliant. And they couldn't stop talking about how great he was in the lab with his technical skills, and how he scored the highest on his in-training exams, and he was great with patients and great with teaching, but really, really great with research and really innovative, really thinking about novel ways that we could develop new tools to make ablation safer in the EP lab. And I do want to highlight something that I thought was really interesting about Arun's work, which was during the pandemic. So the pandemic starts, and I remember, I don't know about all of you, but I was really focused on how do I find the PPE? How do I put it on? When do I gel my hands? And Arun figured that all out. He managed to continue to grow the EP program at Harborview, despite some lack of resources, and also managed to publish 18 papers in the past couple of years, work on 5 consensus documents and a guideline. And this research work was, a lot of it was things you would expect from his CV, things like what are the outcomes of patients undergoing AFib ablation with hypertrophic cardiomyopathy? How can we develop a new tool to protect patients undergoing AF ablation from atrioesophageal fistulas? But also some really novel and innovative stuff like how do you do a totally remote trial looking at QT intervals in patients treated with hydroxychloroquine using ECG technology so that patients don't have to come into clinic during a pandemic? And how do you use smart speakers contactlessly to measure patients' heart rhythms? And I really think that it was the pandemic that really sparked his interest in wearable technologies and the promise of artificial intelligence to use all this physiologic data to really solve some intractable problems we're having in delivering cardiovascular care. And I would be remiss, I don't want to go on and on, if I did not mention that these projects that he does have almost universally been with trainees. Both cardiovascular fellows from our own program, as well as bioengineers, some of which who have won awards for the work that they've done with Arun, and even medical students, which I think says a lot about who he is. So I am really excited to learn from him and hear his talk, From Hype to Reality, Navigating the Limitations and Challenges of Wearable Technologies in Cardiac Arrhythmia Care. Welcome, Arun.
Thank you so much, Chris, for the extremely kind introduction. I have to say, like, Chris has been one of the greatest mentors that I've had, including all the colleagues that I've had, have been incredible at UW. Nazem, Jeannie, they have been incredible mentors. Thank you so much for everything. So let me start with disclosures. So I'm actually on the advisory board for our live core. So there is some data that I'm going to show which has to include our live core, because it is one of the technologies which works in the space. But nothing I showed today will be actually promoting or advocating any of the products. So I thought I'll start with a brief history on the wearable technologies. So it's surprising to, when I was looking at wearable technologies and the history, I was actually surprised to find that the history of wearable technology starts back in 1700s. So Louis Perrelet, he was one of the Swiss watchmakers. So he created an automatic self-winding watch in 1777, which actually uses body movements to regenerate the energy and never has to be wound. So then he went on to develop that technology further, and he created the first pedometer in like 1780. And this was a huge hit. A lot of aristocrats started using this pedometer in 1800s, and a lot of these rich people started using this to measure their step count and keep themselves healthy. And if you look at the ECG, history of ECG technologies and tie it with wearable technologies, like you can see that the first speedometer started in 1780. And in 1900s is when the first ECGs came into clinical use. Antoine like created the first clinical ECG machine. And from then on, like there has been a lot of developments in ECG technology over the last century. And the wearable technologies really started becoming more and more like sophisticated in the 21st century. So 1960s and 1980s, it was the time of event monitors and Holters. And then in 1990s, there were ECG monitors which could actually speak to the wireless handheld devices. And there was like wireless transmission. And in 2000s, the first patch monitor was created, like the Zio patch. And then Fitbit and Apple Watch came in 2000s. And in 2014, the first mobile ECG device got FDA approved, and that was Alive Cardia Mobile. And in 2018 is when there was a big revolution. Apple Watch Series 4 came about, and it had an ECG technology built into the watch. And in some ways, I do think that this was actually the beginning of their wearable revolution. So during this period of consumer mobile health revolution, cardiac arrhythmia field was also growing in exponentially, and it found itself in a very unique situation. So like wearable technology started incorporating ECGs and heart rate monitors, and cardiac arrhythmia field was very well suited to harness this and create tools to monitor arrhythmias and manage arrhythmias. So there were multiple large-scale investigations done in 2010s, and like many of these were company-driven, but these kind of started the revolution in terms of like using wearable technologies for clinical care. In this talk, I was going to focus on the limitations and challenges of the technologies rather than the glory of the technology, because we keep hearing about the glory a lot. But I think it is very important to take the limitations and challenges into consideration if you really want to make use of it in a clinical sense. And so I'm going to focus a lot on the technical considerations, the accuracy of these devices and what hampers the accuracy of these devices, then the clinical applicability of these devices. So, okay, so we can detect arrhythmia, but can we really make a difference in patient's life? So we're going to look at some hard data. So most of the data on technical considerations and clinical applicability belongs in the realm of atrial fibrillation. And in a lot of ways, the field of wearables has focused on AFib for a long time. And it's actually going beyond AFib right now, but still it is very nascent. Most of the meat of the data is on atrial fibrillation. Then we'll look at some of the other arrhythmias and see if we can differentiate other arrhythmias. Then I was going to focus on some psychosocial considerations of wearables, and then like some impact on healthcare burden. This is by no means a comprehensive and exhaustive list of limitations. There are lots of other limitations, but I decided to focus on this because this is like going beyond this, I wouldn't be able to focus on the specific details of some of these issues. So let's start with the patient anecdote. So this is a 59-year-old man. He's relatively healthy. He has like hypertension, but otherwise no other heart diseases. His wife gives him an Apple Watch for his birthday. 4 months after, he starts noticing multiple notifications of irregular heart rate. He notifies his primary care physician. Then Holter finds recurrent paroxysmal atrial fibrillation. He's immediately put on anticoagulation and rate control, and he's referred to a cardiologist. And he's undergoing like evaluation for advanced therapies and see if he's a candidate for ablation and things like that. So let's contrast that with another story. So this is a 66-year-old retired physician. He gets an Apple Watch and uses it for fitness and gets notifications of irregular heart rhythm and visits first one cardiologist and then a second cardiologist. He gets 3 Holters, 3 event recorders, and then a loop recorder. 2 years in, no atrial fibrillation is found, only occasional PACs and short AT episodes. So these two cases illustrate the contrast between the wearable devices, like the outcomes of wearable devices. In the first case, you can clearly see that the patient benefited, and potentially he might have been saved from a stroke. We don't know. But the second second patient who was a physician, he really got hurt by the wearable device. So he got like an extensive workup. He got a loop recorder, which is invasive procedure, although a small procedure. He got a loop recorder, and nothing was found except and what the eventual outcome was like a lot of healthcare expenditure and a lot of anxiety, but we didn't find AFib. So to make sense of this, we need to make sense of the sensor technologies and their limitations. So I'll go over a few technologies that exist in the current world, and let's see like what are the limitations of the current technologies. So if you broadly classify the wearable technologies, it's basically cardiac electrical activity sensors and non-electrical activity sensors. So electrical activity sensors are easy to understand for us as cardiologists. Like these are basically like any ECG device, handheld or a 12-lead ECG or any other kind of ECG device which measures the electrical activity. And when you look at non-electrical activity sensors, these are cardiac sensors which measure the heart rate and heart rhythm, but they depend on some kind of a mechanical impulse to do that. The non-electrical activity sensors can be of two major types. So like you can either have an arterial impulse sensors, which sense the peripheral arteries or the central arteries and figure out how many times the heart is beating, like how fast it's beating and how slow it's beating. The most common devices which do that are optical PPG devices, and then you have like laser photoplethysmography devices. Then you can also have like blood pressure monitors which do the same thing. And there is something called video cardiography which can actually look at the arterial impulse directly. So then you have the cardiac impulse sensors. The cardiac impulse sensors are sensors which actually detect the impulse of the cardiac motion directly. So they focus on the apical motion, and there are different ways. It uses different ways to pick up the apical motion of the heart directly. So these can be sonar-based heart motion sensors, radar-based heart motion sensors. And then there are other technologies like gyrocardiography and seismocardiography and ballistocardiograms. We barely use those things in clinical world because these are usually experimental and research devices, and the accuracy is not that great. So I will touch on the accuracy of these devices a little bit later in my talk again, but I want to contrast that with the arterial impulse sensors. These are usually more accurate, but you can see that these are more intrusive. They have to be on the patient's finger, or they have to touch. And most of these devices on the other side are basically a non-contact kind of sensing devices. So when you look at PPG sensors, again, there are two different types that are in vogue, that are mostly used in the technologies. And many of the mobile devices that we currently use have two different PPG sensors inbuilt in them. One is the infrared PPG. So this is the red light that you get, which chronically measures the heart rate when you wear it. And this is a low energy light, and it is prone to motion artifacts, but it uses less battery. Then there is a second technology called reflected green light PPG. It is basically a green light laser. It has a higher fidelity, but it uses a lot of battery. So it is not always on. So there have been multiple studies conducted comparing the green light PPG versus infrared PPG, and almost all the studies show that green light PPG is much better in picking it up. The sensitivity and specificity both are very good for green light compared to red light PPG. The disadvantage of green light PPG is that uses a lot of battery, so you can't keep it on your Apple Watch or on your wearable. So the green light PPG usually kicks in when you start exercising, and you tell the watch that you are actually exercising. So it starts measuring it more accurately. So that's how the mobile device manufacturers, like, they conserve battery by not keeping it on all the time. So why PPG when you can have an ECG, right? So like now the Apple Watch 4 and onwards has ECG, and you have so many mobile ECG sensors. So why care about PPG anymore? The PPG technology has like major advantages, and that's why they use it in wearables. So one of the first big advantages is that it is easily integrable into any wearable. I'm not talking about just the Apple Watch, but you can also incorporate it in like vests. There is like a textile wearables, and then there is like sneakers. You can put it anywhere, and then it's pretty non-intrusive. And you can monitor patient's heart rate and rhythm without patient engagement. The patient can wear it and forget it, patient or a participant or a user. So they can wear it and forget it, and they can still be getting sampled, and the heart rate can be monitored. And PPG technology also allows for continuous sampling because it doesn't need the patient engagement. So PPG can monitor passively long-term with minimal user engagement, and that's why it's so popular among the wearable technologies. So the problems with PPG. So pulse deficit. So when you have a fast heart rate or when you have PVCs, your heart impulse doesn't correspond to the arterial impulse. So you can have what is called as a bradysphygia, where your arterial impulse lags behind the heart rate, and PPG can get fooled. Like it can underestimate the heart rate, and or it can actually like have a false negative for atrial fibrillation when you have tachycardia. Then skin tone affects accuracy. This has gotten better over the last few years with the laser PPG and like the green light PPG. But in general, darker skin tone has lesser accuracy compared to lighter skin tone. So if you take African Americans or like the darker the skin tone, actually the accuracy actually falls. The other issue is like PPG requires longer episodes of atrial fibrillation for detection. So if you have a 30-second AFib or 1 minute AFib, it won't be able to pick it up. It has to last for 2 or 3 minutes before it can confirm it, reconfirm it, and say it is atrial fibrillation. So bottom line, PPG can be temperamental, and almost always all the technologies that we use, they say you should compare it with an ECG once you have a AFib alert on PPG. Okay, so why atrial fibrillation? Why is there such a big focus on atrial fibrillation from the mobile world, like from the wearable device manufacturers? There are good reasons. Like one is like high prevalence. Like there is a high prevalence of atrial fibrillation among the US population and the world population. In US, AFib affects about like 8 million people. It can be asymptomatic, so picking it up early has value, and it has a significant morbidity risk. But I think the most important reason the device manufacturers are focused on atrial fibrillation is because it is a low-hanging fruit. It is very easy to pick up using PPG, as compared to some of the other rhythms which actually hurt the heart, like hurt the patient and kill the patient, like ventricular tachycardia. So atrial fibrillation is a bit more easier to diagnose with PPG and with irregular heart rhythm. So, and it is actually more common, so you can get more customer base, and you can create a better user base for PPGs. So that is actually something very important that the device manufacturers rely on. So let's go to the atrial fibrillation detection studies. So these are the 3 big studies that have happened in the last few years, like last decade, but mostly in the last 5 or 6 years. So Apple Heart Study and Huawei Heart Study and Fitbit Heart Study, all 3 of them were device manufacturer funded, and all of them use different devices. So basically they have a similar workflow. They all use a mobile-based participation request, and they recruit the patients based on mobile alerts. And then once the participants are recruited, the monitoring is through PPG. And once they have AFib alerts, then they ask them to get a confirmatory ECG monitor or a patch monitor or some other kind of ECG confirmation. So all 3 of them very, very successful in showing that atrial fibrillation can be detected using mobile wearables. They were also very successful in showing another big issue. So the feasibility of mobile recruitment. Apple study was one of the first studies which showed that you can recruit 420,000 patients just by using mobile alerts, and like you can use a mobile technologies to gather recruitment. So this was important, and it will come in some of the other later studies that are ongoing and some of the future studies that are being planned. So the positive predictive value of these studies were anywhere from 84 to 98%, but take that with a grain of salt. The reason is because the compliance with the patch monitor after PPG detection of atrial fibrillation was not ideal. About 35 to 62% of the people followed through with a patch monitor. So the denominator is the people who actually followed through with a patch monitor, not the people who did not follow through. So when you actually follow through with a patch monitor, like the people who are more likely to follow through with a patch monitor are those people who have multiple alerts. Like if they have like multiple alerts of like a PPG detected AFib, they are more likely to follow up with a patch monitor. So that affects the positive predictive value. So all in all, the studies did show that it is possible to pick up atrial fibrillation. The major issues are it was not randomized, there were no control arms, and it was heavily biased towards younger and healthier population. For example, the Huawei study, the mean age of participants was 35 years, and in Apple Watch study, total cohort, only 5.9%, only 6% of the population was cohort was beyond 65 years of age. So it was heavily biased towards younger and healthier population. And the most important issue is that the impact on clinical outcomes is not clear from these studies. So if you do manage to find more AFib, does that mean anything? Like if you put them on anticoagulation earlier, does it actually result in like a hard clinical outcome? You're talking about heart failure and stroke and things like that. Does it actually make a difference? So there are some other small studies which have been done for similar technologies like telecheck AF study, rehearse AF study, and vital AF study. Most of these studies, like Chris was mentioning, happened during COVID. Like COVID kicked off a surge of wearable technologies and using them for different reasons. So telecheck AF study was based on a 6-lead ECG platform. Rehearse AF study was based on single-lead ECG, and vital AF study was either with a device or a physical exam. They actually randomized, and they actually showed that you have similar rates of detection if you do just a physical exam on patient. Bottom line is like all these studies showed that it is possible to pick up AFib. But the big question is, does screening translate to better outcomes? This has been studied in a couple of trials, and the answer is not out yet. It's ambiguous still. In 2021, there was a stroke stop study. They randomized the patients to two groups, handheld ECG screening versus control group, which was routine care. And they did intermittent ECGs for 14 days. They saw that they were able to diagnose 3% of the patients with atrial fibrillation on the handheld ECG group and almost 0% on the other group, control group. On a 5-year follow-up, there was a very small but significant, statistically significant, but questionable clinical relevance in the combined endpoint, like 5.48 versus 5.68. The combined endpoint was stroke and heart failure. If you take the loop trial was a trial which randomized patients to ILR versus usual care. And they showed that when you place a loop recorder, you can have they caught more AFib. So 31% of the patients in the ILR group had AFib and 12% in the control group. But there was anticoagulation was initiated as soon as AFib was diagnosed, but there was no significant reduction in stroke or systemic arterial embolism. So the verdict is not out yet. So there is actually there are some big ongoing studies which are still looking at this question. So does treatment of incidentally diagnosed AFib improve clinical outcomes based on different technologies? RTCI is a study that was happening in UW too, like UW was recruiting for it. PACER and ICD detected AFib. So small amounts of AFib detected on PACER and ICD. Does it, if you anticoagulate versus don't anticoagulate, does it make a difference? Then Heartline AF is a study based on Apple Watch. So they are looking at like real world endpoints like stroke and embolic episodes and other arterial embolisms. And Liverpool Huawei study is using Huawei Watch to do the same thing. And then there is a safer study which is using a single lead ECG to do the same thing. Bottom line is all these studies are looking at detection to stroke impact. Like when you do earlier detection, does it make an impact in the stroke risk? What are the issues with screening? Why does screening fail? So the problem is like screening works if patients are compliant. There are two big issues. So duration of monitoring is very important in AFib detection, and compliance with wearing is also very important. So if you have a condition which is very paroxysmal, it's paroxysmal and it is rare, then the amount of time you can monitor increases the chances of detection of atrial fibrillation. Now, continuous monitoring versus intermittent monitoring, the continuous monitoring will always succeed. Compliance with wear is also important. If you have a patient who wears his Apple Watch for a whole day and then like puts it on charge in the night and has vaguely mediated AFib in the night, we are not going to pick it up. We are going to lose that detection because he removes it for the most important part of his day. The conundrum of mobile technologies is that the more intrusive the technology, the more accurate it is. But it is the patient compliance is less. So like ECG technologies are obviously more accurate, but the patients have to engage with it, and it doesn't help with continuous monitoring. The less intrusive the technology, the more compliant it is, but it is less accurate. So if you look at our study, which we did with smart speakers to contactlessly monitor the heart rhythms, it was an extremely non-intrusive study. So you can just have the patient in the room and like you can detect it. But the problem is it starts failing if the patient is like more than 7 feet away. So it is a less intrusive study, but it is much less accurate compared to a study which would be more intrusive and needs patient engagement. So that problem exists for all sorts of technology which are less intrusive in mobile world. The sensitivity and specificity of any of the current technologies vary between 68 to 100% depending on the patient compliance. So the question was, can we use any sophisticated algorithms to increase the diagnostic yield of ECGs? So there were there was a big landmark study done by the Mayo Group where they looked at sinus rhythm ECGs of patients who had like paroxysmal atrial fibrillation detected at any point in their life. You're not taking the AFib ECG, you're taking the sinus rhythm ECG, and you're trying to see if there are any signatures of atrial fibrillation that can be detected using artificial intelligence algorithms. And they claim that they were able to find atrial fibrillation patients purely using sinus rhythm ECGs. And there was a subsequent study where they showed that there is a 5-fold increase in detection of AFib compared to standard monitoring if you use AI-enhanced ECG detection. We tried to replicate the same study using mobile ECGs, and we used alive core ECGs, 73,000 patients and 260,000 alive core ECGs, and we showed that we can also predict events, but the accuracy was much lower compared to the Mayo Group. Like we showed that like we can predict atrial fibrillation occurrence retrospectively as well as prospectively. Like if you have a sinus rhythm ECG today, and if the patient is going to have an AFib episode 2 days from now, we can actually detect it. There is a higher incidence that we can detect it, or if it can also predict AFib that occurred like 2 days prior. So the problem is the accuracy was not great. The Mayo Group had a very high level of accuracy, but that has not been replicated by other groups which have tried to do the same. What is the current status on screening? So USPSTF currently says that the evidence is insufficient to assess the benefits and harms of AF screening, and they do not recommend AF screening. On the other hand, the European guidelines are slightly more favorable, but they don't recommend wearable or routine ECG use for screening. They say that intermittent ECG screening for patients on an opportunistic basis is favorable compared to like routine screening. So if a patient above greater than 65 years of age comes to your clinic, get an ECG from him, get an ECG for him and do a pulse palpation and physical exam, but don't go and find these people who are above age 65. Not like colonoscopy. So where you start recommending a screening once they start once they come to a certain age, they say like, don't go and screen them, do it on an opportunistic patient if they actually come to the clinic. Okay, so let's look at a different scenario, pivoting from screening to management. So this is a 55-year-old, very athletic commercial pilot with paroxysmal atrial fibrillation. He's status post ablation and doing well. he prefers minimizing in-person clinic visits and clinic checks, and occasionally has palpitations, uses portable ECG, and makes televisit as and when needed for abnormal ECGs only. So does this work? So management of patients with known atrial fibrillation is probably the most likely immediate impact for wearable technologies, although most of the studies have focused on AF detection and AF screening. Although there are no formal guidelines, like on an online survey done by a patient group, it was noted that 71% of the respondents, like they said, like they were already using some kind of digital health device to manage their atrial fibrillation. So the patients are already doing it. Now this could be like a completely biased survey, because like they sub-selected the patients who were engaging with the survey, but there are patients who are already using it, regardless of whether our regulatory bodies have said that it is okay to use it or not. I do think that mobile platforms have enabled novel patient-directed algorithms where the power is with the patients right now. And you can have like on-device analysis of ECG. The patients can get an ECG and they can get an immediate report of whether it is AFib or not. Or you can have a cloud-based analysis using AI algorithms to say whether it is AFib or some other condition. And there are also like vendors coming up with third-party like clinician analysis of ECGs. So it could be, you could be the doctor, you could have a patient and the patient could be sitting at home, but they do an ECG and it goes to a third party and they say that there's a clinician looking at that ECG and saying that you have AFib. Do you want a consultation? And they actually offer a consultation. So that is also happening. So there are different models of AFib management happening already, regardless of the regardless of the guidelines, and it is a matter of it is a matter of us to catch up with these things and figure out what is the best kind of technology that you can use in your clinic and whether it is appropriate for your patient or not. So when you look at management of known atrial fibrillation, there are 4 different things that are major issues. The first one is symptom correlation. When you have a patient with AFib and you have managed them, you can use these mobile ECGs to figure out if the treatment is working well, and you can also use it to titrate rate and rhythm control. There was a study which was done. There's actually a telecheck study, and then there is a telewas study which is going to come up. This is a proposal which is where they are trying to implement the study, but it's in Europe. So the concept is that if you have a patient who has atrial fibrillation and who comes to the ED, instead of cardioverting him, you give them a device and send them home, and then like put them on rate control and rhythm control and try to manage it remotely. If they don't get cardioverted, they can come to the ED and get a class 1C pharmaceutical agent and get cardioverted using an antiarrhythmic agent. So basically using remote monitoring to reduce the cost of healthcare by preventing them from coming to the ED. When you use these technologies to titrate medications, you need to make sure that your patient selection is good. Like the patients have to be facile with available technology, and they should be comfortable with their medications, and they should be able to understand their medications and how to titrate them. And the patient should be able to understand the implications of false negatives and false positives. So the second issue is correlation with risk factors. So more and more technologies these days are incorporating sleep detection and exercise detection. So the technologies have become very good at sleep sensing, like so much so that they can not only detect when you sleep and when you wake up, but they can also detect your oxygen saturations and correlate it with your apnea episodes. So none of them are FDA approved yet for OSA monitoring and OSA detection, but I think it's in the horizon. So like we should be able to see it in the next couple of years, OSA monitoring and OSA diagnosis. So OSA has a big impact on AFib. And if you're able to correlate OSA with AFib by time points, you could probably tell the patient how to impact his AFib, like by giving him a CPAP and making sure he is responding to the CPAP. So the next issue is burden assessment. So can we do burden-based anticoagulation? This is a big this is a big question. So let me illustrate a clinical scenario. So there is a 48-year-old patient with atrial fibrillation, status post-ablation. He's doing great. He's an extreme sports athlete. He's a ski jumper, so very high risk of falls and very high risk of bleeding. He has a CHA2DS2-VASc of 2, but he wants to use Eliquis on a PRN basis. He wants to use it only when he has AFib and not all the time. And he uses his Apple Watch to monitor his AFib. I think we've all met this patient. Like we all met this patient who wants to take his Eliquis as and when needed. So does that work? So intermittent pill in pocket anticoagulation. The concept of as needed anticoagulation is not new. So this has been tested before. There have been 3 feasibility studies, at least as far as I know, which have used different technologies to see if they can feasibly do as and when needed anticoagulation. So REACT-COM was a loop recorder initiated study where they looked at 59 patients and saw the feasibility of as needed anticoagulation versus a continuous anticoagulation. Tactic AF used pacer and defibrillator detected AFib, and iCare AF was daily ECGs, mobile-based Apple Watch ECGs, and they looked at it. So all these studies were small. I don't think you can make any big clinical, you can't make any clinical decisions based on these studies. But the last study of note, it was a 20-month follow-up, and it showed that the GI bleed was higher in the continuous anticoagulation group compared to intermittent anticoagulation group. But there is a big study that is going to start. So REACT AF trial. So and UW is part of this trial, my current institute, Pulse, is also a part of this trial. So REACT AF trial is an Apple Watch based study. It's an ambitious project. It is funded by both NIH as well as Apple. And the goal is to recruit 5,000 patients and follow them over a 7-year period and randomize them to standard of care versus precision targeted brief anticoagulation using Apple Watch. So the concept is you have a patient with a CHA2DS2-VASc of 2 and more with AFib, you give them an Apple Watch, ask them to be off DOAC, and they keep monitoring their Apple Watch. The day they have AFib, they start taking their DOAC and continue the DOAC for 30 days. And if they don't have any further AFib episodes, they stop the DOAC. So it is brief anticoagulation regimens based on Apple Watch monitoring. So we'll see how that goes. There's a lot of money going into the study. And if it turns out to be a positive study, I think it's going to be a game changer for a lot of AFib patients. So the last thing I wanted to touch was drug loading. So we use a lot of drugs for atrial fibrillation. And the most powerful drugs are also the ones with the most side effects. And that includes sotalol and dofetilide. So QT monitoring is a very important thing for sotalol and dofetilide. And most of the centers in the country use inpatient drug loading, where they measure QTs on a bi-daily basis, like 2 times a day. And the question is, can we use mobile devices for outpatient drug loading and keep them home and reduce the cost of healthcare? So we need to answer 2 questions. Can mobile ECGs actually measure QTc? So that is the first question we need to answer. So there have been multiple studies, all during the pandemic, where they have compared mobile ECGs to 12-lead ECGs, and they showed that it is actually equivalent. Like you can actually get a pretty accurate QTc recording using a mobile ECG, and it is pretty comparable in accuracy to a 12-lead ECG. This was our trial that we ran during COVID, where we used mobile ECG monitors for QT measurement, and we used it with Mayo. Mayo was the ECG core, and they were like measuring the QTs for us, but we were using it through a mobile device, and we showed the feasibility. So the second important question is, okay, so you can measure QT using a mobile ECG, but is it safe to keep the patients home and monitor their QTs? What happens if their QT is long? Do you bring them back immediately, or you wait for the next dose? How safe is it? So there have been very few studies and very extremely small studies for sotalol loading. You can see like 3 patients with sotalol and 12 patients with sotalol, and they showed that it is safe to use them. Nobody has been daring enough to do it on dofetilide. And as we all know, dofetilide is much more of a QT prolonging agent compared to sotalol. So I don't think this is prime time yet. So, but there are a few studies in Horizon, and they're trying to build up some studies to see if they can do Dofit-led monitoring at home. Okay, let's go beyond sinus rhythm and atrial fibrillation for a second and look at other rhythms. So this is a patient, this is actually an interesting story. So 38-year-old patient with chest pressure in a transatlantic flight, and they are talking about like diverting the flight and all that stuff and reaching the nearest airport. There happens to be an ER doctor on board who uses an Apple Watch to check the rhythm. So this is the rhythm. You can see it is an SVT, and you do have some ST depressions. So he reassures the patient and asks him to do like multiple Valsalvas. A co-passenger shares his metoprolol and he takes that, and then like, he converts to sinus rhythm. So clearly you can see that it was SVT and the Apple Watch picked up the SVT. So this is another patient with recurrent, this is a published report. So patient with recurrent palpitations and dizziness. So picked up torsades on Apple Watch ECG monitoring. And this is another patient who picked up VT. So you can clearly see that there is PR dissociation, and it was clearly VT. So where are we with beyond atrial fibrillation? Where are we with SVT and VT discrimination? There are case reports and case series. There are social media accounts, but these are difficult to systematically study because of the rarity of the condition and inability of patient to engage with these devices when you are in one of these bad tachycardias. But there are studies which have been done using retrospective ECGs. No, there are not studies. These are like company algorithms which are generated using retrospective ECGs. And you can, like the technology to recognize wide complex rhythms is there. Like the ability to recognize tachycardia and bradycardia, yes, we have that. The ability to discriminate SVT from VT, we don't have any algorithm that can truly do that using a mobile platform ECG. But I think this is where, again, like AI can probably help. And this probably is not so far out in the future. Like we should be able to get SVT and VT discrimination from mobile platform ECGs in the near future. So I'm going to pivot and talk about a completely different topic here, a slightly different topic actually, not completely. So psychosocial impacts of wearable monitoring. So how does it impact the patient, and how does it impact the relationship of the patient with the physician? Okay, let's look at another patient anecdote. So 32-year-old female with OSA, BMI of 32, she gets diagnosed with hypertension. She gets a wake-up call. She decides to change lifestyle, buys a Fitbit, joins a runner's club, picks up running and trains while watching her heart rates, successfully sheds 35 pounds in a year and completes her first half marathon next year. Is weaned off antihypertensives, and per her own saying, she's in the best shape of her life. Let's look at another anecdote. So 28-year-old physician assistant student, persistently elevated heart rates on her Apple Watch, goes to the PCP, undergoes extensive workup, including Holter, event monitor, tilt table test, referral to a cardiologist for inappropriate sinus tachycardia, ultimately started on beta blocker and then ivabradine. Also incidentally diagnosed of anxiety during this time, and he started on anti-anxiety therapy. So the first example is a great example of everything good about a wearable device, where it motivates you and like where it makes you change your lifestyle positively. And the second example is how it can initiate or perpetuate anxiety in certain users. So the psychological impact of consumer wearables, the recognition of both positive and negative psychological effects of utilizing wearables is very important, both for a clinician when we are recommending a wearable, as well as for the patient when they go and buy one. But there are not a lot of big studies. So there are a few studies though, there are small studies, and but we need large scale studies. So the first issue is patient engagement. So there is clear data that wearables and the gamification of these wearables like encourage and incentivize healthy behaviors. The wearables also give individualized risk scores, and they provide personalized patient education and support, and these help with patient engagement. On the other side, you have the somatic preoccupation phenomena. So some people are like exhibit what is called as a worried well phenomena. They're fine, but they keep focusing on their symptoms, and they measure their heart rates often, and they end up with pathological anxiety. So what leads to the first kind of patient, what leads to the second kind of patient, it needs further study. And we don't clearly understand, but there might be a component of underlying anxiety which perpetuates once you start wearing a wearable. The second issue, so connection to the healthcare provider. So there is a perceived connectedness when you wear a wearable, and this has been studied in small studies. And the patients get a sense of being connected to the healthcare providers, and it enhances the patient-provider relationship. And it might actually increase the sense of safety for the patient and the satisfaction with care, because they feel that there is some kind of a backup for them. On the flip side, it can also lead to unnecessary and frequent contact with the medical system. Like you can have patients who are worried well and like who go into the anxiety loop, multiple phone calls, multiple messages, unscheduled patient visits, and for small and normal fluctuations in heart rate. This creates an adverse relationship with healthcare providers. And as much as we claim to be impartial, like there is always a psychological impact on us, like when we deal with such scenarios. The third issue is real-time feedback. So feedback from wearable sensors and biosensors is immediate, and that might actually improve adherence. So if a patient notices that he starts wearing his CPAP and next day he has less burden of AFib, that improves adherence. And it also gives the opportunity for self-management, like rate control medications. You can get like immediate feedback, and then you can control and titrate your medications. On the flip side of that, you have false reassurance issue. So if you have insufficient education among the patient group, they might feel that they don't have AFib, but they could have AFib, but it could be a false negative. And that leads to a false sense of security and safety, and they might actually miss their anticoagulation dose, like in that instance of pill in the pocket anticoagulation strategy. So if the AFib is not picked up due to whatever reason on the PPG, that can lead to a false sense of security and a real hazard. So recognition of positive and negative psychological effects is very important. Large-scale studies are required, and hopefully we should see some big studies come up in the next few years, because this is being recognized more and more in the not only in the cardiovascular world, but also in the psychology world of psychology. So I'm going to touch on burden on healthcare system for a little bit. So this is actually a very important issue, because this leads directly to clinician burnout. So let me give you an example, clinical scenario. So 72-year neurologist, AF status post ablation, very worried about his risk of stroke, monitors his rhythm with Apple Watch and cardiac monitor daily, sends multiple ECG strips weekly to confirm normalcy, leads to adjudication by nurse, then by an MD each time, leads to clinical action such as patient phone call or secure messaging, then clinic visits and documentation burden. This is actually one of my real patients, and I had to have the patient come to the clinic, and I told him, like, this is what is happening on the back end, like when you send these ECGs. He was a very sweet patient, and he immediately understood what I was saying, and like he said, like he'll do his best to cut down on the number of ECGs that he sends. But this is not an uncommon scenario. This happens quite often because patients don't realize what kind of a burden it creates for the healthcare system. The biggest issue is the false positives. So when you have a patient with very small burden of atrial fibrillation, the amount of false positives is always going to exceed the true positives. So there are studies which have shown that, like, when you take a population with low prevalence of atrial fibrillation and put like wearable monitors of them, you're going to have more false positives than true positives. And that is just the nature of the problem. So if you have a patient with high degree of AFib, it's not useful in that patient, because he needs to be on pills and medications anyway. And if you take a patient with low risk of AFib, you're going to have false positives. Then inconsistency between the device brands, that is a big issue, because a lot of device brands use their own proprietary algorithms, like sensitivity and specificity differ among the different brands, and that leads to issues. Then electronic medical record integration and workflow do not exist currently. They are under development, but that is a big issue, because we need to be able to see it and seamlessly read it. And like once we don't have that, we are doing all of this work on the back end with poor workflow. So lack of reimbursement or poor reimbursement is another issue, and that needs to be addressed. So this is a very interesting like news article that came about like about 3 months ago. So Apple Watch released iOS update where they would actually detect car wrecks, and they said like if you like we can detect car wrecks, and when you have a car wreck, we will notify 911 immediately. So like skiers in Nebraska started detecting car wrecks because these people were skiing and coming to an abrupt halt, and it detected it as a car wreck and like started calling 911 immediately. And they say that the cops were buried under an avalanche of false alarms. So this is one of the issues. Like this goes to show how the technology companies do not understand the clinical workflow and how this impacts the clinical workflow and the healthcare system. So data deluge is a real problem, and that needs to be recognized and proactively solved. We need appropriate integration and dashboards to like measure these things, and like sorting needs to be done. You need to have like low alert system, high alert system, and things like that. So when we did this study during COVID, we had Mayo do our core lab for ECGs, and they created a dashboard for QT monitoring. So they created a dashboard, and the dashboard worked in a couple of fashions. So the first was an AI screener. So the AI screener would look at the ECGs, and it would put them in different buckets. Like it would have a yellow bucket and a red bucket. The yellow would mean that there is a small QT prolongation, and the red bucket would mean that a clinician needs to see the ECG immediately. So the yellow buckets would go to the ECG technician, who would confirm the QTC, and if the QTC was a false alarm, he would actually put it as normal. But if the red bucket directly meets physician, and the physicians would read it. So we need that kind of seamless technologies so that we can have an AI sorter which sorts out some of the issues and then brings the real problems to the clinician. Otherwise, the clinicians are going to burn out. So when you look at, if you're hoping for a mobile health technology integrated arrhythmia care in the clinic, you need integration all the stakeholders need to come to the table and like contribute their bit. So the device manufacturers need to come out and have consistent standards and develop need-based technologies, not ease-based technologies. They shouldn't be developing what is easy to develop and then like putting it on the clinicians to figure it out. They should be working with the clinicians to develop need-based technologies. And there should be a responsible labeling of clinical utility. You can't claim to figure out car wreck when it can actually have a false positive with just keying. So you need to have responsible labeling of the clinical utility for these devices. When you take clinical researchers and physicians, there is a lot of responsibility on us. We need to welcome the mobile technologies into clinical trials, and that's how we're going to be able to assess the accuracy and the clinical utility. And in a lot of ways, it is our responsibility to work with the industry and tell them what is important and what is not, and guide them towards achieving the right goals. And then we also need to develop and design trials and studies which focus on hard outcome focused evidence. From a healthcare system standpoint, EHR integration should be a priority. Whether we want it or not, we are going to face a future with wearables, and we are going to get a lot of information from the patients with wearables. This is only going to increase as the millennial age group ages and start having cardiovascular problems. Everybody is very savvy, and they can use wearables. So we are going to get this. The data deluge is going to happen. So we need to be prepared for that. And we need to invest in personal training and then pathways and infrastructure to integrate it into our EHR system. We need to get ahead of it, and otherwise the clinicians are going to burn out, and it's going to be a vicious cycle. From a regulator and payer standpoint, we need to push for cross-platform standards which are equivalent. Like device manufacturers have reasons to patent their algorithms and keep it proprietary, but it doesn't help patients in the end or the clinicians. So we need to have cross-platform standards which are universal, and we need to have faster audit pathways. It should not take a long time for us to for the regulators to audit these pathways, because the technology develops at a very fast pace. And creating encouraging reimbursement models is very important to encourage adoption and proper use of technology. If the reimbursement is very poor, it will not get integrated into the healthcare systems. And we know that from different scenarios in the past. Like for EP, we are unique. Like we have had like multiple rounds of remote technologies. Like we have had like ICD and pacemaker remote technologies, and there were multiple workflows that were created because there was a data deluge initially, like when the pacer RPM technologies came up, and then there was an alert-based monitoring where a lot of alerts would actually be sorted out, and then like you would actually get like the sorted out alerts. Or there was actually like a 3-monthly pay reimbursement model for pacemakers and defibrillators. That was to encourage remote monitoring. Otherwise, it was not going to be adopted. So they needed to create a reimbursement model to encourage adoption. So to conclude, wearable devices have significant potential in arrhythmia care, but the limitations should be recognized. The limitations currently are due to accuracy, consistency, and burden issues. But the psychological impacts are also huge, and studies need to be performed for large-scale studies are needed in this space. AI-based techniques might actually help enhance the quality of care and experience for both patients as well as physicians, but this remains to be seen. Thank you all.
Thanks, sir. That was fabulous. Oh, Dr. Dechek has a question.
Yeah, I have a request for a compliment first, and then a request and a question. So thank you very much. I really feel brought up to date by this presentation.
Thank you.
It was really excellent. My request as somebody who's active in the field, I made this to you. But it seems that a lot of the data that you reported are reported as fold increases. That can be extremely misleading. You know, if you go from 1 million to 4 million, it's still very, very, very bad. And it would be, I think, far more informative to report data more in absolute quantities than in full increases. I would, if you can encourage it, to move in that direction, and that would be great. The question I have involves, maybe I misinterpreted a study I read long ago, or I'm not in contact with the area, but in terms of this fill in the pocket anticoagulation, wasn't there a study a number of years ago that kind of disassociated stroke from episodes of atrial fibrillation detected by monitoring? And if that's true, doesn't that sort of remove the rationale for that approach?
That is absolutely true. There are pacemaker and ICD studies which have looked at correlation of atrial fibrillation and the timing of stroke. The REACT AF actually goes against that hypothesis, right? Like, but I don't know if we know enough about it. So if you have AFib burden of like 1%, does it mean that like the timing of the atrial fibrillation should correlate with the stroke, or 1% burden actually means a higher risk factor? We do not know that. So if a patient goes from 1% to 0%, does it actually mean a decrease in stroke? We do not know that answer either. So the timing doesn't correlate in some of the studies, but then there are some of the studies which show that when you do a pill in the pocket based on certain parameters, then it can actually have an impact in the stroke. These are smaller studies. There is one study that I showed, I think it was a REACT-COM, which used pacemakers and defibrillator-based detection, and it showed a smaller decrease in. It did not show a decrease in stroke, but it showed a decrease in bleeding.
It would be particularly hard in a study like that to enforce compliance. You know, some people are going to take it a little longer, a little bit less long, and I think that's going to probably muddy the results, unless that's
that is true.
Extremely close.
That is true, yeah. And in REACT AF, the big caution is that the patient should be able to wear it continuously for a long period of time during the day. If you don't wear it in the nights, then the study becomes irrelevant, right? So like you need to have an extremely high level of compliance.
Thank you for talking. I was wondering, what do you think is the prognostic, and clinical significance of incidence of arrhythmias found with more different screening. For example, there's a postdoc analysis like a new trial that came out of Denmark. I don't have the specific numbers up in front of me, but amongst the treatment arm versus the usual care arm, there was, I think, a six-fold increase in arrhythmia, that was 50% increase in treatment replacement, but without significant difference in sudden death.
So you're talking about incidental arrhythmias, which are not the target of the monitoring, but you find something else. Yeah. So the clinical significance is not clear. So and I think like incidental pickup of those things will lead to increased expenditure, and that is a concern. There was a sub-study done for stroke stop study to see if these kind of incidental issues do lead to increased burden of healthcare and increased cost. And it was actually shown that despite these pickups of incidental findings, the cost of healthcare actually goes down if you do a monitoring using wearable technologies. But I think the debate is still on that. So.
Last question, hold over.
Thank you, Arun. I was wondering, you had that nice slide before the end, sort of all the stakeholders, different perspectives. One thing I wondered about is sort of medical legally how this information is kind of being handled and where liability or responsibility is about to lie. I think about an example like the number of cardio strips one gets in like an inbox, and
Right.
the backlog is, of course, you don't want to miss, an important diagnosis and triage patient,
Yeah.
but it's easy to get buried against that. And there's companies sort of helping generate this huge flood of data who don't do what you mentioned, all the workflow issues, understanding that. But has there been any comment about with whom that responsibility lies to manage the data when there's an important diagnosis being made?
It's a tough question. Nobody knows the answer to that. But it's a great question. Yes. So when you do, when you get a lot of these, so there is one study, a very interesting study, which was done on physician burnout and clinician burnout. What it says that the more responsible a clinician is, the more is going to burn out. Right? Like if you actually constantly think about not missing every single diagnosis, you're going to burn out earlier because you will actually like look at all the data, and you have only so many hours as the other guy too, right? So like the problem is when you get these reports and there is a pathway for it to come through, and if you create a reimbursement model for that and somebody is paying for it, there is also like a reduction in the number of contacts with the medical system. So that might be actually that might actually control the number of visits you do to the doctor or number of reports you send to the physician. That doesn't exist right now. So when a patient sends a report to a physician, they can send as many as they want, and that increases a huge burden. I don't know. When I was dealing with it, like I didn't have a good way of dealing with it. So I don't know if Chris has a better way to do it.
No.
Yeah. So, and that is a problem for us, like in the pacemaker and ICD world too. But at least we have some layers of protection in pacemakers and ICD. So we have groups of device nurses and like remote monitoring companies which are doing these things and like sorting these data out before it reaches us. So at least we don't get alerted for false positives.
Thanks, everyone. I think Shridhar will stick around for a few minutes if he has time.
Thank you.
For questions. Thank you.